Good day everyone. Today, I'm gonna discuss about the acute respiratory distress syndrome, including its etiology, pathophysiology, clinical manifestations, diagnostic procedures, treatment modalities, as well as its managements.
Acute Respiratory Distress Syndrome, or ARDS. Definition: Acute respiratory distress syndrome occurs whenever there is acute, diffuse, and uninflammatory form of lung injury or a severe form of acute lung injury. And according to Siegel 2015, this clinical syndrome is characterized by a severe inflammatory process causing diffuse alveolar damage that results in sudden and progressive pulmonary edema, increasing bilateral infiltrate on chest X-ray, hypoxemia, unresponsive to oxygen supplementation regardless of the amount of PEEP, or positive end expiratory pressure, and the absence of an elevated left atrial pressure. So now, let's talk about the etiology of acute respiratory distress syndrome. Etiology: it is the cause or set of causes or manner of causation of a disease or condition. The causes of ARDS can be direct or indirect injury to the lungs. Sepsis and pneumonia are the most common causes, and it's graded based on the severity of the changes in atrial blood oxygenation. Indirect lung injury, it includes pneumonia, aspiration of gastric contents, pulmonary contusion, and near drowning. While in indirect lung injury, it includes the sepsis, severe trauma, multiple transfusion, and drug overdose. In infection, such as sepsis and diffuse pulmonary infections, it is caused by viral mycoplasma, pneumocystis, or pneumococcytis pneumonia, miliary tuberculosis, and gastric aspiration can cause ARDS. In physical injury, such as mechanical trauma, including head injuries, near drowning, fat or air embolism, and burns also cause ARDS. In inhaled irritants such as smoke, oxygen, toxicity, irritant gases, and chemicals can cause ARDS. And the other factors include acute pancreatitis, obesity, drug overdose, cardiopulmonary bypass, and thoracic surgery. So now, we're moving on to the pathophysiology of ARDS, or acute respiratory distress syndrome. The acute respiratory distress syndrome is an inflammatory form of lung injury that can either cause by direct or indirect lung injury and occurs when tissues are injured by infection, trauma, toxins, or any other cause. There is an initiation of inflammatory immune response. Inflammatory triggers initiate of the release of cellular and chemical mediators. They travel up to the right side of the heart and then travel into the pulmonary or lung circulation. And there, because of the rich blood supply to the lungs and very thin thickness of the epithelial tissue, there's a transfer of these inflammatory mediators into the alveoli of the lungs, and this can initiate the inflammatory response and cause corresponding issues. Inflammatory triggers initiate the release of cellular and chemical mediators, causing injury to the alveolar capillary membrane in addition to the structural damage to the lungs. Alveoli collapse because of the inflammatory infiltrate, blood fluid, and surfactant dysfunction. while the small airways are narrowed because of interstitial fluid and bronchial obstruction. And the lung compliance may markedly decrease, resulting in decreased functional residual capacity and severe hypoxemia. The blood returning to the lungs for gas exchange and pumped through the non-ventilated, non-functioning areas of the lungs, causing shunting. This means that blood in the interfacing with non-functioning alveoli and gas exchange is markedly impaired, resulting in severe refractory hypoxemia and resulting in a respiratory failure. Severe refractory hypoxemia is where the patient will remain or maintain as low blood oxygen level even though they are receiving high amounts of oxygen. And now, we'll be discussing about the clinical manifestations of ARDS. So ARDS have three phases, including exudate phase, proliferative phase, and fibrotic phase. The exudative phase, the duration of this phase is typically up to 7 days and usually begins within 12 to 36 hours after inciting insults. It develops hypoxemia, which low level of oxygen, tachypnea, respiration rate greater than normal resulting in abnormally rapid breathing, and dyspnea, which is shortness of breath. While the proliferative phase, it is the recovery phase. And although most patients recover, some will develop progressive lung injury and pulmonary fibrosis. In this phase, allowing removal of mechanical ventilator support and dyspnea and hypoxemia often persist during this phase. And lastly, in fibrotic phase. In this phase, most patients recover within 3 to 4 weeks of initial pulmonary injury, but some experience progressive fibrosis, necessitating prolonged ventilator support and supplementary oxygen. The signs and symptoms of ARDS that typically appear between 1 to 3 days after the injury or trauma include shortness of breath, fast breathing or taking lots of rapid, shallow breaths, fast heart rate, coughing that produces phlegm, blue fingernails or blue tone to the skin or lips, fatigue, fever, and crackling sound in the lungs. Assessment or measurement of diseases that can be observed or noted in the patient. These are: note that the skin color of the patient is pale, note that patient appear anxious or exhausted, note that patient is unresponsive to the questions, and note that patient is seldom talk in sentence and tend to give short answers to questions or use nonverbal communication. And now, let's proceed to the diagnostic procedures. ARDS is a medical emergency, and an early diagnosis may help them survive to the condition. A doctor or physician can diagnose ARDS in several different ways. There is no definite test for diagnosing this condition. The doctor may take a blood pressure reading, perform physical exam, and recommend any of the following tests. The following test includes blood test, chest X-ray, CT scan, throat and nose swabs, an electrocardiogram, an echocardiogram, and an airway examination. X-ray is an imaging test using a small amount of radiation to produce pictures of organs and tissues in the body. CT scan is a computerized tomography scan. These images provide more detailed information than normal X-ray image. Electrocardiogram, it is a painless test that measures heart's electrical activity. Echocardiogram test that using sound waves to produce live images. And now the treatment modalities. The treatment modalities begins with treating underlying medical and surgical disorder, prophylaxis against aspiration, treat nosocomial infections, provision of adequate nutrition, and monitor arterial blood gas values, pulse oximetry, and pulmonary function testing. In medical management, there is no specific pharmacologic treatments of ARDS except supportive care, and neuromuscular blocking agents, sedatives, and analgesics may also use to improve patient ventilator synchronization and help them to decrease severe hypoxemia. Also, inhaled nitric oxide, an endogenous vasodilator, may help to reduce the ratio of ventilation to perfusion mismatch and improve oxygenation. The following are the nursing diagnoses related to ARDS or acute respiratory distress syndrome. Ineffective airway clearance related to aspiration. Ineffective breathing pattern related to compensatory tachypnea as manifested by inability to meet metabolic demands. Deficient knowledge related to unfamiliarity with the disease process or transmission of disease. Activity intolerance related to general weakness or fatigue, and impaired gas exchange related to inflammation of airways and alveoli. The nursing interventions include identify and treat cause of the acute respiratory distress syndrome, administer oxygen as prescribed, position client in high follows position, restrict fluid intake as prescribed, provide respiratory treatment as prescribed, administer diuretics, anticoagulants, or corticosteroids as prescribed, and prepare the client for intubation and mechanical ventilation using PEEP, or positive end expiratory pressure. And now the prognosis in ARDS. The prognosis of ARDS are more directed to lung injury. Patients with acute respiratory syndrome caused by direct lung injury are twice as likely to die than caused by indirect lung injury. But the functional recovery in patients with ARDS, majority of patients recover lung function. However, there are also factors associated with less recovery function when there is low static respiratory compliance, high level of PEEP or positive end expiratory pressure, longer duration of mechanical ventilation, and high lung injury. And that's it for today. Thank you for listening. God bless.